Okay, I think we're ready to start. Is everybody? Yeah, everybody's there. Welcome, everyone. Welcome to CDEP's conversation series on global health. My name is Erta Kalanji, and I will be moderating this webinar today. I just want to make sure everybody can hear me. So if one of the panelists can tell me if everything is working perfectly.
Yep, fine.
Great. So this is the first of our series, webinar series that we are organizing in relation to celebrating 10 years at CDEP. And the webinar today, the first session, is in connection with the release of the State of the World's Antibiotics report in 2021. We are delighted to have here with us today distinguished experts in the field of AMR. And we are really looking forward to some good conversations on the progress and the challenges that lay ahead with regards to AMR globally. So towards the end of the session, we will answer some of your questions. If you are following us on Zoom, please enter your questions in the Q&A section. If you are following us live on Facebook, please enter your questions as comments under the live feed. Joining us today, we have Professor Otto Cars, founder and strategic advisor of REACT and a senior expert at the Public Health Agency of Sweden. We have Professor Abdoulaye Djimdé, president of the African Association for Research and Control, and an associate professor at the University of Bamako. We have Professor Dame Sally Davies, UK's Special Envoy on AMR. We will close on AMR and Master of Trinity College at Cambridge University. Finally, we have Professor Ramanan Laxminarayan, director at CDEP, who is going to start the discussion today by introducing the State of the World's Antibiotics report. Over to you, Ramanan.
Thanks, Erta, and welcome to all of you. So, Erta, I think the live Facebook feed is not working yet, and you might want to turn that on now.
It is. We are live right now.
We are live? Okay.
It says in here that we're live on Facebook. Perhaps okay. you might refresh.
Okay, I'll just try that again before we start again.
Okay.
Okay, great. Okay, so thanks everyone for your patience. You know, this is the first of 10 webinars that we have planned to commemorate the 10th anniversary of CDEP's founding. And we naturally thought we should start with the topic that CDEP is best known for, which is really antimicrobial resistance. So we really appreciate all of you joining us, you know, for this important landmark year for us. There will be other webinars that cover other topics over the course of the next 10 months. But this particular one is really to launch a report called the State of the World's Antibiotics. The last time we did this report was back in 2015, when things were very different with AMR. In 2015, there had been some progress on AMR, notably Europe and the United States had already made progress in terms of national action plans. Many other countries had, as part of work with the Global Antibiotic Resistance Partnership and other partners, including REACT, which is represented by Otto Cars here today, had already made some progress on AMR, but by and large, the world had not moved in a collective way. It was only in 2016 that there was a UN General Assembly and a high-level meeting which was focused on AMR, the fourth time ever that a health topic was featured at that particular gathering. And it really helped provide a significant impetus to this important problem and the solution by making sure that all countries were agreed that this was something that the world could solve only if done collectively. Now, since 2016, it's now been 5 years, and not quite, because this was 2016 in September, so we're about 4.5 years. And some countries have made a lot of progress, but many countries have lagged behind. Now, we have not tracked AMR in a global way, in a systematic way over this period of time, It was something that some of us had argued for at the time of the 2016 UN declaration, that there should be targets on antibiotic resistance, on consumption, but many countries were reluctant to be held accountable for specific targets. But we think now that 5 years later, the lack of progress on this issue has made it important for us to again argue that without measurable targets, it will be hard to make progress on AMR. So that's number one. Number two is that this idea of One Health, the idea that human, animal, and environmental health are all related to each other, has received a lot of attention now in the context of COVID, because now we realize that COVID could have come from animals and transmitted to humans. And so in the public consciousness, this idea of zoonotic disease and One Health is now, very prominent. And this again is an idea which, in the context of AMR, has not really achieved, the correct response from countries that it really should have. So, in presenting this report, we hope to bring the attention back to the One Health nature of antimicrobial resistance. And I'll present a few slides to show you exactly why we think that this is really the way to go. But one of the things that this report does is really provide an exhaustive presentation of dashboards for many countries on antimicrobial consumption, on resistance, on and also of drivers and correlates of antimicrobial resistance. So that's the second point. The third point is really something which will be discussed in the context of the panel, which is on global governance. Now, as part of the 2016 UN General Assembly and the high-level meeting, there was another panel that was set up, which was then to spawn another set of panels. But all this in 5 years has really reached nowhere. There is a global leadership group now for AMR, which we welcome. It's co-chaired by two prominent women prime ministers in the world, and it's something which we hopefully will see a lot of action on. But for now, we have not really seen much there yet. In the meantime, countries are still struggling to get out of COVID, and they will be ill prepared to really deal with antimicrobial resistance. Now, COVID itself has provided a context for AMR to get worse, which is that with a lot of people crowding into hospitals, a lot of the infections, the secondary bacterial infections on COVID patients, are actually caused by bacterial pathogens. So again, in many ways, AMR is making COVID worse, and it's quite visible to people who are studying this. So I'm just going to go through a brief synopsis of the report, and then we'll start the panel discussion. But again, I thank you all for joining, and it really is a pleasure to show this work on behalf of the many collaborators who've worked on it. It's been about 2 or 3 years of very intense work, and we're really proud that to be able to share this with you today. So this is essentially the state of the world's antibiotics in 2020 as things stand. When we look at, so all of this work has come out, in various forms, but it's really being summarized here for the purpose of this audience. Now, there's a significant amount of variability in per capita antibiotic use across the world. So panel A on the left, top left, is showing the weighted average resistance. Defined daily doses consumption per capita in high-income countries, and the right side is showing the same information in low and middle-income countries. And you can see that particularly of penicillins, but even cephalosporins, there's increasing amount of consumption that there's not much of a difference anymore between what's happening in the LMICs and what is happening in the high-income countries. And meanwhile, if you look at resistance, and which is down here, which is in high-income countries, and here in low and middle income countries, you see that resistance is actually higher in low and middle income countries, particularly in contexts where people will not be able to afford second line antibiotics. So regardless of which antibiotic you think of and what the bacterial pathogen you're referring to, we see fairly high levels of resistance. I would pay attention to the y-axis. This is 80% out here and 100%. And you can see that levels of resistance in low and middle income countries are extraordinarily high, exceeding 20% in many instances and going as far as 80%. Now, we compute what is called a drug resistance index, which in very layman terms is a way to communicate the problem of resistance to a lay audience that doesn't understand biological names like Acinetobacter baumannii or Klebsiella pneumonia or Staphylococcus aureus. So just like a stock market index is a weighted average of the, the price of multiple stocks that are on the index, in this case, the drug resistance index is the weighted average of resistance in a particular country, weighted by how frequently that antibiotic is being used to deal with that particular pathogen. And we've now been doing this for about 10 years, and we see that there's a significant variation in the drug resistance index. Now, keep in mind, the higher the drug resistance index, the worse the problem of resistance. And it's a combination of having high levels of drug resistant pathogens and also not having newer antibiotics that could deal with those drug-resistant pathogens. So in some cases, if countries are using more advanced antibiotics, also they could have a lower DRI. And you can see that the DRI is particularly high in India, Thailand, Ecuador, Venezuela, also in South Africa, Turkey. Turkey's a significant per capita consumer of antibiotics. We have confidence intervals here based on how much data we have for this. And you can see that some of the countries which are doing much better are countries like Sweden, which Otto can speak more to, and Canada, Norway, Finland, which have managed to keep resistance down through a combination of optimal use of antibiotics, but also of preventing unnecessary use of antibiotics. Meanwhile, between 2000 and 2015, and we're now updating this for more recent years, antibiotic consumption has gone up in many parts of the world. You look at French West Africa, it's gone up 4 times. Dr. Djimdé can speak to this. Antibiotic use in China has gone up about 50%. Remember, all of this is per capita numbers. And so, this is DDTs per 1,000 people. So these are strikingly large increases in per capita consumption, and obviously correlated with income, but not really with any sort of disease. And include, you could see for Brazil and Saudi Arabia as well. Now, the World Health Organization uses 3 categories for antibiotics, which are access, watch, and reserve. Access antibiotics should be available freely. Watch antibiotics should only be used in the context of a stewardship program, and reserve antibiotics really should not be used at all. But what we see is that the consumption of access and watch antibiotics has increased, but particularly the watch and in some cases the reserve antibiotics have also increased. So you can see that in the high income countries, the increase has not been so much. So that's all in the blue. But the greatest increase, which are in the yellow and the red, has really happened in Latin America, some across Africa, and then also in Oceania. So you see that as a global sort of a phenomenon. Now, we've also looked at we've done a lot of studies on vaccination as a possibility to reduce the incidence of AMR. And we think that vaccination really should be scaled up for routine issues like pneumococcal pneumonia, even rotavirus, because vaccination both leads to fewer infections and less antibiotic consumption, but more directly, it also leads to lower disease burden and less transmission, all of which leads to lives saved. So we see that this is going to be a major focus for the world to make sure that new vaccines are introduced. Now, last but not least, it's really also about using the antibiotics that we have appropriately. And some of the work that's presented in the report is based on global work that we've done along with partners on how to have stewardship programs function even in low resource settings. So we've got manuals on how to do this, and we've got checklists, and it's possible to have, even in low resource settings, programs to be able to use antibiotics appropriately. So it all comes down to the same 2 things, which is reduce the need for antibiotics, which is through vaccination, water and sanitation, and infection control, and reduce the use of antibiotics through good stewardship programs. Now, if you look at global antibiotic consumption in animals, which is the other piece of where our attention has really been, for the first time earlier this year, we were able to quantify the amount of antibiotics that were used in aquaculture, which, although is only a small proportion of the overall antibiotic consumption, is still significant. And you can see that humans are at the very bottom, then cattle, then chickens, then pigs, and fish. And you can see that all of it has been going up, but you could see that the total consumption outside of humans is much greater than the consumption within humans. So this is a natural sequitur from the fact that the world is demanding more animal protein. But if we raise that animal protein using only antibiotics as really growth promoters, we are really headed for trouble. In work that was published in Science about a year back from us and again collaborators, what we also saw for the first time, which had been done at a global scale, was that antimicrobial resistance is also increasing in animals. Now we saw an increase across chickens, pigs, and less so in cattle, but certainly in chickens and pigs, which is where the bulk of the antibiotics are really used. Now you might ask, are we concerned about this primarily because of a transfer to humans? I would say partly, but I would also remind the audience that these animals, whether they're chickens or pigs, are sources of livelihood for most people around the planet. Anyone who's poor is really depending on these animals for their sustenance. And if those animals were to get sick with drug resistant bacteria and were to die, then it represents an economic loss for many people in poor countries, but also in the poor in wealthier countries. So we should be concerned about antimicrobial resistance, even if it's happening outside of humans, because it represents an economic cost. Now, we've looked at ways of reducing antibiotics in food animals by 2030. We've looked at a business as usual scenario under which consumption go up significantly, but it can be reduced through regulations, by people consuming less meat, not necessarily becoming vegetarian, but certainly just consuming less meat. Maybe a user fee on antibiotics, or a combination of these measures. And the best of these combinations can curtail this increase by as much as 80%. And this was again the work that was published in Science, and it shows that it is possible to address this problem provided we do it quickly. Now, last but not least, we also see that new antibiotic development has has improved between 2013 and 2019. You can see that all the bars on the right side are certainly looking a little healthier than the bars on the left side, particularly the drugs that have been approved and the ones for which applications have been filed. But this is still not sufficient. Many of these are still not for the priority pathogens that the World Health Organization has laid out. And we still have a lot of work ahead of us. Colleagues at entities like GARD-P and CARB-X are working hard to be able to fund with public monies private companies to be able to develop new antibiotics, but this still remains a project of the next 10 or 20 years, and we still have a long way to go. Now, I'm going to show you a couple of examples of the dashboards. They're a little small to read, so you might just go to our website and download the report so you can see it. You can see that for India, for instance, we have policy indicators. Are they enrolled in GLASS? Do they have AMU surveillance in humans, AMR surveillance in humans? Do they have a national action plan? And in this instance, in India's instance, there is no AMU surveillance in animals, for instance, but there is AMR surveillance. We're looking at resistance indicators on a few key pathogens like MRSA, carbapenem resistant Enterobacteriaceae, ESBLs. And then we've computed a DRI for some countries, but not for all countries. We have information on animal resistance, again, on use indicators in humans and also in animals, and then public health indicators, because we think that these are all correlates of antibiotic consumption. And work that we published in the Lancet 2 years ago, we found that these were important drivers in predicting resistance. How good the vaccination program was, how good how strong the health spending was, and so forth. And right at the bottom is really these expenditures, which is on government health expenditures, what proportion is out of pocket, and so forth. What we urge countries to do is to adopt this kind of a broader dashboard look to track progress on AMR, rather than just looking at just percentage resistance, which is a very, very narrow indicator. AMR, by its very definition, is a complex problem which is multi-sectorial, involves a lot of work in sectors outside of the health sector, and there is really no way to tackle this problem unless we deal with it in a multi-sectorial way. And that requires tracking a lot of indicators, which are, which are going to be diverse and widespread. But this is where we really need to make progress. And we can see the same sort of indicators for a high income country like Italy, for instance, a country like Croatia, which is an upper middle income country. And what we see is that resistance is a problem in most countries, but a bigger problem today in low and middle income countries, driven by increasing antibiotic consumption in some of these countries. Increasing antibiotic consumption itself is not a problem. In fact, we argue always that increasing access to antibiotics amongst people who previously did not have access is an important goal. You have to remember that even in a country like India, about 150,000 children die every year because of lack of access to just penicillin. So on the one hand, we have a lack of access to a simple drug that costs, literally pennies. And on the other hand, we have resistance because of people buying extremely expensive antibiotics that they absolutely do not need. How we solve this problem is not going to be, it's not going to be an easy problem to solve because it requires both making the penicillin available, but also curtailing access to newer antibiotics that may not necessarily be needed. But then that also has incentive problems from the side of pharmaceutical companies that are trying to develop these drugs. But all said, AMR is really going to be the challenge, the global health challenge that is always in the background and probably increasing after COVID has receded. But we have to keep in mind that this is not a problem that we can wish away just with a vaccine. It's not just going to be solved with one vaccine, and this is really why it's going to take years of work to really get there. So we have data also on China and a number of other countries. The references are all in the report, and I would encourage you to go to resistancemap.org, which has a lot of these data, but also to the CDEP website to download the report and share the report. So with that, I'll stop here, and thank you all again for joining. Over to you, Otto.
Thank you, Ramanan. Thank you for that very nice presentation. We are now planning on heading over to our speakers. We have a few questions for them, and we'll start with Otto Cars, Professor Otto Cars. So, Professor Cars, you've been involved in pushing for global coordination on AMR for a long time. How optimistic are you that that will actually happen?
Well, thank you very much. First of all, congratulations to a 10-year anniversary, and thank you for letting me participate in this webinar. Well, for sure, at times I've been really frustrated about the slow pace of how this has been moving. And Ramanan already alluded a little bit to the history, but we can go even back to 2001, when there was the first WHO strategy on antimicrobial resistance, but there was no funding or implementation plan. And in fact, the same is happening now. We had the Global Action Plan in 2015, which really created a much greater momentum, but still what countries are facing is funding and for capacity building. And it's not yet strongly integrated into the national policies as it shouldn't be in the background, Ramanan, it should be upfront in the foreground. We really need to make this issue the issue of the COVID-19 before the next virus pandemic, because we have already an ongoing pandemic. On antibiotic resistant bacteria. So I think we need to reflect on why AMR has been so low on the agenda for many years. I think there are at least three major factors. First, AMR is not a disease, so we lack burden data for sure. This is a critical barrier. Secondly, and connected to the first, is there is no civil society movement to work on this. I mean, this may be coming, because there is a recent UK study on interviewing oncologists that foresee that much of chemotherapy will be unviable for the coming years because of antibiotic resistance. And REACT also recently published a study on a survey on international pediatricians, and they say that 50% tells that they see antibiotic resistance as a major cause of deaths in neonatal sepsis. So we need to voice up the problem much more. But for sure, the third factor is over-reliance of the pharmaceutical industry to continuously deliver new antibiotics. I believe that this misperception has delayed political momentum for years. And so we need to overcome these barriers in understanding, and we need to voice up clearly to the policymakers. So, I mean, over the years, there have been numerous declarations promising global action, commitment, collaboration, and so forth. And the latest, most important one, as alluded to by Ramanan, is the political declaration from 2016. But we have certainly come now to a point where we just have, where the governments and the agencies and the international community must deliver on these commitments and create a common vision to preserve this global resource and secure sustainable access to effective antibiotics. So, I mean, during COVID-19, we missed, unfortunately, an opportunity for a second high-level meeting at the UN. But I think, no doubt, that the momentum on AMR is still here. I hear that there are 500 people listening into this webinar. That's a good crowd. And we have a special division at the WHO on AMR, which is new, quite new, and again, the newly formed Global Leaders Group. So back to your question, am I optimistic that global coordination will really happen? Well, I will borrow an answer from the Swedish health actor Hans Rosling, telling that it's never too late to give up. So let's do it some other time. Never give up. Yeah, sorry. Okay, thank you. I can't hear you.
You're muted.
Apologies, my apologies. Yes, I was going to say that you have partially answered my second question, but it's an important one, so I'm going to say it again. How can we better then communicate the challenges on AMR in a One Health manner, provided the context of the COVID-19 pandemic?
I think absolutely that we need to realize that COVID-19 offers great opportunities to reset the agenda for antibiotic resistance if we're working together to strengthen the narrative, because this pandemic has clearly led to an unprecedented understanding of the global risks from weak public health infrastructure, including sanitation and infection control, as well as functioning research agenda globally and supply chains and so forth. So I think there are three ways that we can work up this. I need to move this phone because I can't see my screen. To make to really use the opportunity of the challenge and make antibiotic resistance much more understood. First, get more data again. Secondly, describe the pandemic dimensions of the spread of antibiotic resistance. And thirdly, apply a systems perspective. I mean, today we get real data, daily data on the deaths of COVID-19 and the numbers of infections of COVID-19. What about antibiotic resistance? We're far, far, far from that. So we really need to have a much more swift and encompassing surveillance system. Burden data is lacking, and in many countries, as also alluded to in your report, such as Africa, there is nothing really. There is no guidance, there is no surveillance available to guide the prescribers. So this essential gap needs to be filled. And secondly, I think again, describing antibiotic resistance as pandemics. I mean, we can see it as waves of pandemics really. The MRSA, we have the ESBL and the carbapenemases now. So I think that language could really be used forward to move antibiotic resistance into all the discussions on pandemic preparedness. And then lastly, the systems perspective. I think the narrative is not there yet. And I think moving up the problem in the systems perspective, where transformation of systems need to be sustainable in health, agriculture, and environments, is a way to describe it to policymakers. And if you could put up my first slide, just show one example of how you could describe it and how you could describe the real sort of fundamental pillars of all. The first one, please. The other one. Yeah. This is just one example, and I think many of you are using the same. Antibiotics are critical pillars for all health systems. Basic medicine, specialized care, not the least modern medicine and cancer treatment and transplantations and so forth. This is something that needs to be conveyed all the time. And if you go to the next one, if you look upon how this is taken up in the country, we have the National Action Plan, but the National Action Plan needs to be very well coordinated and integrated. All these four pillars: prevention, data generation, awareness and behavioral change, and access and conservation need to move hand in hand. Because if you have a surveillance system, you can generate some data on resistance. They need to be used for treatment guidelines, for procurement, and so forth. It all need to be integrated in this systems way. And I think you could see the same thing developed also in the other areas of the One Health perspective. So this is how I see it. This is a real, I come back to that later. This is a critical point in how we need to address this, really. Thank you very much.
Thank you very much. We're now going to move over to our next speaker, to Professor Djimdé. And I just have to, okay, great. So, Professor Djimdé, we have a question that is more related to the African countries' context. So, AMR is a growing challenge in Africa. What kind of institutions and resources will countries in Africa need in order to feasibly develop and address this problem?
Okay, thank you. I think I'm speaking on behalf of the African Association for Research and Control of AMR, which is a sort of civil society type of organization. It's a scientific society with membership in about 30 African countries, from Morocco to South Africa. And we are actually constituted to fill some of the gaps that Prof. Otto mentioned in his remarks. The current situation is that each of the countries are ramping up with national action plans and naming a national focal point on AMR, but the majority of the countries, these action plans still need to be signed off by the relevant authorities before they can actually benefit from resources and actually start being implemented. So I think, and the other problem is these, in our view, the focal points, the stage where they are in the hierarchy in the government is such that their efficacy is going to be problematic, at least not to the level that we would like to see this important problem to be. So I think there is quite a bit of uplifting of the national focal points that we would see happening in Africa, given the magnitude of the problem and the growing nature of the problem. So we would like to see increased political will, and the governance of AMR to be brought up to at least the Minister of Health level, or even higher, the Prime Minister or the President's office level, such like the HIV commissions that we see around, and or the COVID commissions that we see around. I think that would be important to be able to really tackle this problem in Africa. At this stage where you have the national focal point, somebody down there and swamped with many responsibilities, it's just going to be difficult to deal with coordinating effectively coordinating the national action plan on AMR. I think part of the problem is that the lack of data in Africa. In report after report, you really see very little hard data coming from African countries to the disposition of the political decision makers. So we do need to come up with data that is crafted in a manner that the politicians can understand it and the communities can understand it, and from there frame messages that would resonate with the communities and the political leaders. Problem is recognized as a major problem, as a pandemic, like Prof. Otto was saying, and dealt with at such level. There again is something our association is trying to tackle, because we realized by being on the ground, we realized that there's actually quite a bit of data on AMR, but it has not been published in the peer-reviewed literature. So there's a great literature, quite a bit of theses in the form of PhD theses or master-level theses, reports from various NGOs that are around, that if they were to be made public in some form, either in publications or in some sort of repository, or made in a more visible and user-friendly manner, can fill the gap of data. So that's some of the things that we would like to do and are trying to do in our Pan-African association. And the next thing that I would flag is training in terms of building the human capacity to deal with the various aspects of the AMR. That also there is a lack of experts in many fields, especially in this field that is fairly newly recognized as on its own right. There is very little experts. So we think that we need to tackle the human capacity resource development in a big way. In that sense, we at the Action in collaboration with the University of Science and Techniques and Technologies of Bamako in Mali and African colleagues, we are launching a master's degree in the science of AMR, which we think is going to train the needed human resources that would be manning those AMR committees that we are calling for, and moving down the road, actually bringing the AMR issue at the bench, at the university level, at college students, at medical students, pharmacy students, to actually help them grow with an increased awareness of the problem, so that when they become professionals, they can be more sensitive to the issue and push the agenda forward. So these are the citations we.
Thank you very much. These are some very interesting points, especially the one on publication, the gap in publications. That's not something that I had considered before. We are running short of time, but we have one more question to ask you, and if you could be brief, that would be very much appreciated. We will get back to speaking again. You know, we have questions coming in from the audience, and we are encouraging them to write continuously. So we've gotten some interesting ones. So very briefly, how can innovations in molecular and epidemiology help us in tackling AMR?
Yeah, this is also an important question, and there is an increasing development of capacity in terms of sequencing, in sort of generating genetic data, analyzing genetic data. I think this is going to be very useful. The AMR field has to jump on the train with the rest of the initiatives that are promoting the use of genetics in general in infectious diseases, and help in where it can help is in better tracing the genetic development and selection and spread of AMR, and putting us in a situation where we can actually be proactive. Right now, the situation is we are being reactive. We wait until the resistance is in the clinic and people dying from before doing anything about it. If we use molecular biology and genetics, we can actually pinpoint the problem before it even reaches that level and be preemptively act on it, as a few examples have demonstrated it.
Thank you very much. Thank you very much for your insights. I see that we have been joined by Dame Sally, and we have some questions for her. Hello.
Hello. Let me say how sorry I am to join late. I was at a meeting of the G7 countries talking as the UK's president about AMR, so and we've got to focus on it, so that's good news. And then before you ask me a question, happy birthday, Sida. You've done a great job till now. You're coming of age and we want you to do even better. So happy birthday.
Thank you very much. I guess Ramanan is taking this happy birthday quite personally. Yes, we have a few questions for you. You played a significant role in the 2016 UN General Assembly meeting that called for global action on AMR. What do you see as concrete improvements in AMR global governance since then?
Thank you. Otto and Ramanan also played significant roles, and it was an exciting moment. And frankly, we have lost momentum since then. So it took far too long to set up the interagency coordination group, and then they recommended the global leaders group, and it took far too long to set that up. And the first meeting was last week, and I'm honored to be a part of that. But the first meeting was mainly about introductions and what could be done. We need a plan. I think the chair, Her Excellency Mia Mottley, the Prime Minister of Barbados, is really fired up, and I think she'll be good. And, you know, women get things done. I'm hopeful we'll do things. But you know what we're also missing? If you look at climate change, you see the IPCC. We haven't yet got that independent panel for AMR. The Global Leaders Group is One Health, and I think that's important because we've got to go forward One Health together, but looking at the problems in each particular area. And because it's a macroeconomic issue, I am pleased that the World Bank said they would apply the AMR lens, but I'd like to see that really gaining energy and traction and happening much more. We're doing quite a lot of work with investors out of Britain and activist investing and getting AMR into what's called ESG, economic, social and governance issues, but we've got more to do. I hope we can use the G7, the G20 and the platforms that are there using the momentum that COVID has given us. But frankly, we lost it and we're going to have to work hard to get it back as we need it.
Thank you. Thank you for that. So are we getting any closer to setting global targets on AMR so that the world has a sense for whether progress is being made?
Well, targets, there's always a lot of debate. I think they're really useful as long as they are achievable and stretching and move you forward. So the best place for them is clearly in the national action plans. And we know 135 countries have finished those. We have targets in our national action plan and we're really trying. But we can't just leave it to countries. We've got to act collectively. And I think it's a really complex area. And that's, again, let me go back to the IPCC, how the climate change people use the evidence to help set the targets. We need a mechanism where we can have independently recommended targets that maybe the Global Leaders Group then asks the UN to buy into. But we need to use mechanisms that are very similar. And that's, again, I suppose why I'd argue for doing it maybe that way, because the targets have got to impact on the problem. And that means people and the food chain. So that they've got to be targets that inform policy making, innovation, and they can't just be limited to antibiotics. We've got vaccines, we've got other therapies, we've got infection prevention and control. So where would I start? I think we start with voluntary targets and commitments to phasing out antibiotics for growth promotion. We've managed in Britain to reduce our use of antibiotics in the food chain by 42% between 2011 and 2018, just by targets and voluntary action. We've managed to reduce our human use too. So I think we can do that, but don't forget the role of investors and the role of consumers. McDonald's, Tesco's, and Costco, as examples, responded to consumers. So we've got to try and use not just targets on governments and actors, but actually other ways of putting in targets that are more creative.
Thank you. One last question. What is your reaction to the dashboard approach to track AMR in a One Health framework?
Well, I've always liked dashboards, so I think it's fantastic. And actually, I think if you look at what's happened in COVID, you can see that dashboards that are available and accessible and shown to the public and the politicians have demonstrated the urgency of the issue. So I think we need to think about the best way of displaying limited bits regularly, that where they're going badly or well. We're going to need history as well so that we can show the changes. Going back to 2010 is a great idea, because we've got to build that narrative, and perspective is really important. I've been doing a big piece of work which has been led by our Office of National Statistics on a health index for the country to put beside GDP. And in fact, it's now up for a consultation and discussion. And I've learned from these experts about how if you do it really evidence-based, you can get all sorts of people buying into it. And then watching how COVID has become the noisy, acute pandemic, we need to think through AMR as the silent pandemic. How do we do it? But I think it also feeds into, investments in WASH, in IPC, and in vaccines. It's all part of what we're trying to do. And underpinning doing it is that question of capacity and capability. So our Fleming Fund, which you will know, working in a number of countries, 24 countries, has actually supported 14 countries to enroll in glass. And I think that's a great start. And I love what Zambia's doing, where they've got a real-time stewardship and data collection app on phones, which other countries are now picking up, which allows us to get the data to feed in, but actually allows them to think about what they're doing. So yes, the dashboard, great.
Thank you very much. I think we are ready to address some of the questions from the audience. I believe Ramanan has answered to some of them, but we'll start with one question. It's directed to everyone. We've been talking about the global context so far, but this question is taking us back to where AMR is quite prevalent, and that's in the community. So stewardship programs in the community have shown to be effective, yet they're not very highly funded. What is the issue? Do we need a better business case? That was a question of the audience. Yes. So it's open for you guys. Okay, I see a raised hand here.
Well, I could take that question only to say that it's absolutely right that stewardship is not very well funded in hospitals and also in the community, for the simple reason that Otto mentioned, which is that unlike COVID, imagine that COVID had just been like the normal flu and no one was testing for it and people were just getting infected and dying. There would be no attention on COVID. There'd be no vaccines for COVID. Nobody would know anything about COVID. It is only because we recognize it as a separate disease, that we test and track it, that there is all the money that comes into it and that we're solving the problem. We have essentially this problem with AMR, which is Unlike COVID, it is invisible. And without that visibility, we will never get the attention or the funding in. I mean, is it hard? If you think of what the world has spent on COVID right now, 160 plus vaccine candidates, that level of attention and research could easily solve, many of the problems that we have for AMR. In fact, the ask of the world for AMR is a fraction of what has been spent on COVID. But without the numbers and the attention, it's not going to be possible to get that money, which is why we all have to work collectively to shine the spotlight on the numbers. It's going to be really important to show who is suffering. Without that, funding at all levels is going to be limited.
Thank you. I'll move on to another question, if that's okay. So one of the participants is asking, is the concern regarding the use of antibiotics in animals only on the negative economic consequences that it has? Or is there evidence that this contributes to AMR in the environment that can potentially have an effect on humans?
I think we've addressed that already, Erta.
We have?
Yeah, it's already in the answered box. So you might, there's some on the open list.
Okay. Another one is asking on if we could give any examples of where good stewardships have led to a fall in the percentage of number of resistant cases.
Yeah, here again, I think I would point. Otto, go ahead. Otto is the king of the talk, but I was going to point this out.
No. But for sure, I agree on the previous question. I think it's absolutely correct that we need some more data. I mean, we have the glass, but it's moving slowly. We need some point prevalence approaches. I think the AMR community could go together, put some protocols up for measuring antibiotic use in a very simple way in the communities, not the least in the low and middle income countries. And then go to global funders to get this done, because data is data for action. I think that's absolutely key. I think, yes, there are some countries that have shown bending curves on antibiotic resistance, for sure, in Europe, in the Scandinavian countries and otherwise. It can be done. I mean, for sure, if you, and that is also a very great argument for getting funding from the government, that you can show decrease in antibiotic use leads to decrease in resistance in community pathogens. And as well decreasing costs. So I think data, we need to really get more data on the ground in a coordinated way, in parallel to when glass is moving along slowly.
Can I just come in? Because of course, stewardship is about ensuring access when they're needed and not using them when they're not. And I wanted to pick up on Otto's point. I wish I could remember the exact figure, but when I wrote as chief medical officer to all our community physicians, the general practitioners, and well, no, I didn't. I wrote to the top 25% prescribers, randomized half of them, and they reduced use by 3%. We actually saved millions of pounds, as well as reducing the risk of antimicrobial resistance. So there are financial arguments for doing it. I mean, we went on year after year writing the same letter because we saved so much money that the National Health Service thought it was a great idea. So, there is an advantage to doing it as well. But the final bit about stewardship I just lob in is, of course, about quality of the drugs as well. Thank you.
So this brings us to a question that is relevant to this last comment. New antibiotics are expensive, one of the participants asked, and using them is difficult due to the enormous costs. Are the national action plans in development going to tackle the cost of new drugs as well?
Can I go first on this? I think this is a really critical issue because we need to, the word is solidarity. We have seen some solidarity in COVID-19, but it's not perfect, as we all know. Vaccine nationalism. I mean, if we badly need new antibiotics, and as Ramanan alluded to in the report, the low middle income countries are worst off with the resistance, and they have the greater need. But we need to find a system where research and development is moving much stronger globally in coordination, but also where the end product is making accessible and affordable to everyone in need. This is the only way to look upon the equation, and then we need to look upon other areas in medicine where this has happened, and where pricing are dealt with in an equitable way. So access is absolutely key.
So
go on.
You first.
Okay,
Please,
well,
Prof.
I think there are a number of issues. One, we don't have enough innovative new drugs, so we need to look at how to make those happen. The next issue is how are they costed? And I do think we've got to make sure that they are accessible to the people who need them wherever in the world. So somehow we've got to balance this of paying more in the rich countries to pull the new drugs through, but making them accessible. And I think that this is going to be difficult, but it's doable. But until we have new drugs, we're going to have a problem. And at the moment, there's another issue. For instance, the drug, and I should remember the name, everyone else will, that Archaeogen was producing, they went bankrupt. They were bought up by Cipla. That drug is now only available in the United States. Cipla say it's too expensive to register it in Europe. So it's not just the low-income countries that are not getting access to these drugs, whether it's a cost or availability. There's something wrong with our systems globally about registration, access, and cost as well.
Okay, so yeah, it's what I was going to say is a bit along those lines, because there's we need to strike the right balance between the cost of the R&D and how to make sure that it will we don't deter the pharmaceutical companies in investing in new drug. Yes, yet we still need to make the drugs that are available accessible. I think to be able to balance all of these, we probably need to, the community as a community, come up with creative ways of funding R&D in maybe bringing in public money to support the pharmaceutical industry to help them in research and development. One other aspect one would probably can consider is paying more attention to looking into developing anti-infective agent from local pharmacopoeias, from traditional medicine, herbal medicines, that are, in my view, being sort of overlooked or less exploited into researching for new anti-infective agents. Over.
Very good. I don't know. I think we maybe have time for one more question. And one of them, it's a difficult question that it's been covered sort of, but maybe it's more, I feel like I have to repeat it again. What would be the estimated cost of AMR in Africa? Is there any number? Can anyone put like can quantify this in some sort of way?
So we're working on this, which is just on the burden of AMR. I think before we put it on cost, I think the first step is really on trying to figure out the numbers of infections that are caused by AMR in different countries in the world. And the reason for that is it gives us first a sense of a ballpark figure of how many infections there are before we even get to mortality or anything beyond that. And even that first step is something which is taking up a lot of time to really do. And I have to say that so just to also catch on to the question from Tim Jinks, communicating that scale of the problem is also important for national level policymakers, because they're not paying attention to webinars like this one, they are looking at the problem within their country, which they don't see. And they also perhaps see that, oh, AMR is too difficult. There are 100 things that I need to do to fix things to make it really happen. And I also think that's a really important point, that we have to communicate a solvability of a problem. COVID, it was solvable with vaccines, so it was straightforward. It was solvable with masks. Now, they might be hard to implement, but it was only 2 or 3 things that people really had to do. We have to do this. We have to say, here are 3 things to really do. I think Otto pointed to a couple of these, Sally did, and Djimdé did as well, which are, we've got to really, nail down 3 or 4 things: removing antibiotics for growth promotion, improving infection control, improving vaccination. And 3 or 4 things are all that we really should focus on. And I hope that's what we've tried to do in this report as well, rather than boil the ocean to be able to solve AMR.
Well, we have sort of reached the end of we're going over time now. We've reached the end of our session. So I think we will have to end the webinar here. But first, before that, we would like to thank you very much, say a very big thank you to our speakers that took their valuable time and they gave their insights into this very important global issue. The report is available for download on our website. And I would also invite you to visit our website for future webinars in this series in the next coming months. So thank you very much for your attendance, and have a great day, and we hope to see you next time.
Bye-bye.
Thank
you.
Bye-bye.
Thank you.
Bye-bye. Thank you.
Thanks
Thank
for
you.
the opportunity.
Thank you. It was a pleasure having you all.
Thank you.
Thanks.
Great. Well, that was really good. Thanks, Djimdé, Otto, and Sally, and thanks, Erta. Fabulous job.
I'm sorry about the mix-up with the time, saying it live right now.
Yeah.
No problem. Thanks a lot. Thanks for the opportunity.
Erta, thank you very much. Erta, could you capture all the chat in the chat box? I can't do it from my phone here, so we can